When to call it as PPH? What is PPH? Postpartum hemorrhage. So when do you call it as hemorrhage? More than? What is the normal amount of blood loss in a patient with normal delivery without episiotomy? Without episiotomy. Listen my question carefully. Without episiotomy. I didn't give episiotomy. She delivered. So what will be the amount of blood loss? So if it is without episiotomy, normally it will be around 250 to 350. With episiotomy, it will be 500 ml. Cesarean section, 1 liter. Whereas if it is for cesarean hysterectomy, greater more than 1.5 liter. Okay, these are all the bits you need to remember. So normally to call it a PPH, it should not be more than 500 ml in a case of normal delivery. In a cesarean section, it should not be greater than 1 liter. So if it is more than that, then we call it as PPH. How do you divide PPH? Early and late PPH. What is early PPH? When do we call it as PPH? So within 24 hours of the third stage of the labor. So within 24, how many stages are there? What is third stage? Third stage is delivery of baby, delivery of placenta. Delivery of baby is which stage? Then third stage is placental delivery. So delivery of placenta is third stage. So mostly the bleeding will be in the third stage. That's why we are calling it as postpartum hemorrhage. So early means within 24 hours from the third stage. If there is PPH, we call it as early. Late means between 24 hours and 6 weeks after delivery. So within 24 hours the patient will be totally fine. Next day if you come and check the patient for normally, the patient will be in a pool of blood. Okay. So that is called as late PPH, early PPH and late PPH. Why we divide it like this? Because the main reason is the causes of early PPH is different from late PPH. What is the most common cause of early PPH? Atonicity of the uterus, the most common cause. Why the patients land in PPH is atonicity. What are 4 T's? Tone. The 4 causes of PPH are 4 T's. Remember it as 4 T's. Tone. One is tone. So if there is lack in abnormality of the tone. The second T is tissue. What do you mean by tissue? Retained placental products. You feel that the placenta is out. So the important thing is once you deliver the patient, you need to check the placenta totally, whether the cotyledons, everything are out. So if you might be missing one cotyledon inside, it will cause severe PPH. Retained product, that's what we call it as retained products of conception. So tone, tissue. Next, trauma. What kind of trauma we are expecting? Any trauma, episiotomy, cervical lacerations, vaginal lacerations, extensions, okay, pelvic hematomas, anything can happen. These are all trauma. Then what is thrombus? Coagulation disorders. The patient will be having coagulation, sickle cell anemia. The bleeding will not be controlled. The patient will be having ITP, idiopathic thrombocytopenic purpura. The bleeding will not be controlled. Okay. DIC, the patient will be in DIC. The bleeding will not be controlled. So any thrombotic disorder. So these are all the very important causes. They are asked very frequently for you regarding the causes. That's why I gave you a clue. Remember 4 T's. Tone, tissue, trauma, thrombus. So we'll see in detail. What is the most common cause? Uterus atonicity. The uterus will not retract. So normally the uterus will contract. So what is difference between retraction and contraction? Retraction is permanent shortening of the muscle. Contraction is it will shorten, once again it will come back to its normal size. Whereas in case of retraction, it is permanent shortening. Okay. So once after the delivery, within 24 hours after the delivery of the fetus, the uterus will try to retract. That's what we call it as retraction. After 24 hours, it is only contraction. Okay. Immediately within 24 hours of delivery, it is retraction. That's why, because the uterus, what is going to happen? Once you see during the time of delivery, after delivery, the uterus will be until which size? Immediately after delivery, where? Up to the level of umbilicus. PG bit for you once again. So immediately after the delivery, if you see the uterus, it will be at the level of the umbilicus. But it will reach the pelvis by, it will become normal organ by normal, it will attain the normal size by 12 weeks. Purpurium, that's what we call it as purpurium. So it will, these are all the changes what are all going to occur in the purpurium. So once the size of umbilicus means how many weeks? Lower border of umbilicus. Lower border of umbilicus is for how many weeks of gestation? Middle border how many? So this is umbilicus. This. Now tell me. This is pubic symphysis. Pubic symphysis how many weeks? It becomes pelvis organ by uterus becomes a pelvic organ by. Very basics, frequently asked questions. How do you measure the size of the pregnancy? Ila cheppu. Yeah, how do you measure? It becomes pelvic organ by first how many weeks? 12 weeks. So until the 3 months completed, first trimester how many months? 3 months. Trimester means 3 months. So first trimester until 3 months you cannot palpate. 12 weeks it is going to become a abdominal organ. So from pelvic organ it is going to become an abdominal organ. 12 weeks. Put your 4 fingers. It will be in the middle. How many weeks? 16 weeks. So now tell me lower border of umbilicus corresponds to 24. Okay. Next here what is this? What is this? Next 4. Next 4. Next this is what? Giphisternum. It will be. That's it. Okay. 40 weeks it will come back once again with flanks fullness. It will be 32 weeks with flank fullness means 40 weeks. Okay. Is it clear now? Why did we go there? Okay. Retraction and contraction. So the uterus once it starts retracting at 20 weeks uterus will become a normal size uterus because it will contract permanently. That is what called as retraction. So now we go in detail into the causes. I will show you. So first atonicity. Where can we see the atonicity? So all are the causes of atonic uterus except this was asked previously. So where do we see big uterus? Uterus will not retract or contract properly because if it is a big uterus. So where do we see big uterus? Huh? Yeah, okay. Next, multiple pregnancies, polyhydramnias. Next, where do we see big uterus, atonic uterus? Because the uterus will not contract because it is big. Next, polyhydramnias, twin pregnancies. Next, other causes, grand multiparous. Next, grand multi. Yeah, I have seen even a lady, she is delivering around her 16th pregnancy. During my PG period, she came for her 16th delivery. So, grand multiparous, super grand multiparous. So, over distension of the uterus. Over distension of the uterus is, where do we see over distension? Come fast. Sit fast, settle. We are discussing the topic of PPH. We finished pre-eclampsia management, treatment, drugs, antihypertensives. We have finished. We entered into the PPH, postpartum ephemeris. Those who came late. Okay. I am discussing about the causes. So out of this, one cause is tonicity. Okay. One is grand multipara. Next is over distension of the uterus. Be careful. Once the patient enters into the third gravida itself, there can be chances of PPH. So whenever you are doing a delivery of the third gravida, even second gravida also, don't assume that everything will be normal. You feel that it is normal. After 1 hour if you come and see, she will be lying in a pool of blood, approximately in a state of shock. They may not know. They feel that that is a normal bleeding. So always any multiparous, be careful. The chances of PPH is very, very high. Anemia. So this is also one of the cause why the uterus will not retract properly. Anemia in the mother. Next. So prolonged second stage of the labor. And one more thing I forgot about in eclampsia. The very important thing is the management of the eclampsia or pre-eclampsia. Always cut short the second stage of the labor. Okay. So what are all the indications to cut short the second stage of labor? When should you cut short the second stage? Why you are cut shorting the second stage? First of all, tell me, why can't you wait until totally? We are in a need to deliver it fast. We have some other methods where we can cut short the total process. Where her total, because already severe pre-eclampsia or mild pre-eclampsia, anything can happen. The abruption can happen at any time. The patient can throw fit at any time. Okay, we need to cut short the one. What is the main pathology of this eclampsia or pre-eclampsia? Main culprit is Placenta, main culprit is placenta. So we want to remove that placenta out first. So what we are doing, we want to cut short the labor. So what are all the other conditions where we cut short the second stage of labor? Other than preeclampsia, where do you want to cut short? Either it can be forceps or ventouse. Where do we use it? No? Placenta previa you want to put forceps and deliver. The placenta will be down there. How do you deliver placenta previa by applying forceps? Where do you want to do a fast delivery? Fetal distress, very important. If the fetus heart rate is slow, already it is at the 0 station or +1 station. Now I can take the patient for cesarean section because already it is at +1 to +2. But still, because of maternal, one thing is fetal distress. Any indication of fetal distress if it is at +2 station. But the baby has landed in fetal distress. Now I can't take her for what is +2 station? It is above the ischial spines or below ischial spines? What is 0 station? So ischial spines. So at the level of ischial spines is which station? Suppose if the head is here, 0. So from here 1 centimeter, 1 centimeter, 1 centimeter, +1, +2. Suppose the head is 1 centimeter below, it is ischial spine +1. 2 centimeters below, +2. 3 centimeters, +3. What is -1, -2, -3? The same thing, go above, okay? -1 above, -2, -3. If it is still above, what do we call it as? Floating head. The head is floating. For abdominal, you can nicely feel the head, okay? These are all the stations. Okay, where are we? Why did we come? Cut short the second stage. Cut short the second stage. One more indication is heart disease. Very important. Cut short the heart disease because once the patient gets contractions, the load on the heart is going to be more. So you want to cut short and prevent the heart landing in the failure. So one more indication for cut short the second stage of labor is heart disease, medical complication. Okay. Next, other indications. Prolonged second stage of labor. Any prolonged second. When do we say prolonged second stage of labor? What is the normal duration in multipara or nullipara? Duration of second stage. Nullipara and multipara. Which one is 30 minutes? 30 is multipara. 1 hour in nullipara. So if it is greater than 2 hours in nullipara and if it is greater than 1 hour in multipara, we call it as prolonged second stage of labor. So once the second stage, what is second stage? First of all, tell me. మీరిద్దరే ఆన్సర్ చేస్తున్నారు, వెనకాల ఆన్సర్ చేయండి. I want to give a break for both of you. You please wait, let others answer. So what is second stage of labor? What is second stage of labor? Delivery of fetus. So from full cervical dilatation to the delivery of the baby. So that's what we call it as second stage of labor. So second stage of labor, normal duration in a primi is 1 hour, in a multi is half an hour. If it is greater than 2 hours in a primi and greater than 1 hour in a multi, we call it as prolonged second stage of the labor. So if the second stage of the labor is prolonged, now I want to put an outlet forceps or anyway either ventouse, whatever may be, depending upon the circumstances. So one of the indication is prolonged second stage of the labor. Any medical conditions. So even that conditions also I want to cut short the second stage of the labor. Next, any fetal distress. Is it clear? So these are all the indications. So these are all the conditions where we can see the atonic uterus. And one more, any induction, especially oxytocin use. Oxytocin is going to cause, at the same time oxytocin is the drug used for PPH. Okay. So all drugs, if they give you oxytocin, it is used in PPH. It is the first line of drug which is used in PPH. Okay, we are going to give oxytocin in PPH management. But excess oxytocin, if you give excess oxytocin, it is going to cause atonicity of the uterus. Okay. Anesthesia, this was asked for you. Epidural anesthesia or epidural. Where do we give epidural? Either in painless delivery or even in case of cesarean sections nowadays we are giving. So in any case, if the analgesia is given, it is going to cause atonicity. And already the uterus is along with fibroid uterus. Why the fibroid will cause atonicity? Normally the uterus will retract, but Now here the contraction and retraction is affected because of the in-between fibroid. So the uterus will not contract properly and precipitate labor. Okay, these are all the indications. Every cause was asked for you. Every cause was asked previously. Okay. Coming to trauma. So one is stone, second is trauma. Now we discuss about trauma. So what are all the traumatic conditions where there can be excess bleeding? So episiotomy. First of all, what is episiotomy? When do we give episiotomy? When do you give episiotomy? I want to put plaster to both of you. So what is crowning? What is crowning? When do you say it is crowning? Pushes the cervix. Cervix spine untadi. Crowning bite ikkada head. So normally what do you see? Once the uterus contracts, the head will be pushed out. So you are able to see head outside only during contraction. Once the uterus relaxes, automatically the head will go inside. But crowning means even during relaxation, the head should be seen outside. Okay, that is the time where you are going to give episiotomy. Okay, that was asked for you. So either relaxation or contraction, you should be able to see the head outside. Okay, at the level of the vaginal outlet. That is, during that time you need to give episiotomy. So what is main thing episiotomy is there can be many blood vessels. So even during that process it can cause severe bleeding. Episiotomy, cervical lacerations, the most dangerous. Once the patient cervical lacerations occurs, they will bleed very profusely as if like we have opened the tap. We don't know, even before we identify the site, it will be bleeding heavily, the patient will be in shock. So the cervical lacerations are the most dangerous bleeding sites. The cervix should not be injured. Once it is injured, that's it. It's very difficult to identify the cervix and suture it. Okay. So cervical lacerations, paraurethral tears. Above the urethra, there can be paraurethral tears. And the thing is uterine rupture. Total, the uterus can rupture sometimes. So these are all the causes for trauma. Next, what is other T? Tissue. Okay, tissue I have left it. I will discuss in next class. That's related to different topics. So what comes under tissue? Any retained products of conception. So retained placenta can be there, retained membranes can be there, anything retained. Okay. Next, what is next? Thrombus. So thrombus, it includes any coagulation disorder. So abruption, in abruption there will be coagulation disorder. Yes or no? It will be there. In abruption the coagulation factors totally will be affected. Either it can be even in jaundice also, because the liver parameters are altered. So the metabolism is also altered. So in jaundice and HELLP syndrome and DIC. So these are all the conditions where the coagulation can be affected. Okay. So how do you manage this? The first thing, so you have delivered. Don't think that is a very rare condition. It is very common condition. Once you enter into the labor room, you can see PPH more frequently. And as once you enter into the house surgeon period, I don't know how far you have seen, but we had an excellent batch of house surgeons while I was doing my PG. Even though the patient lands in PPH, we will be managing the patients outside, because that will be total hectic. For one bed, already 3 patients will be sitting. So there will be a huge number of patients, but only 2 or 3 PGs will be in duty. So house surgeons used to manage excellently. Even though the patient lands in PPH, they'll take every treatment, and they'll make the bleeding stop, and they'll come outside and they'll tell that everything is fine. So that's how they used to manage. So important, the management of PPH is very important, because you have got 1 year service. Yes or no? Meeku leda 1 year service? No? No, cancel? Okay. Meer ఏ batch? Which batch you are finalists? Meer? House surgeons. Okay. You don't have 1 year? Okay. Unna vallakaithe meer నేర్చుకోండి. మీకు PG కోసం నేర్చుకోండి. So what we need to do, first thing is it is not a single man management. Same thing, any emergencies, call for help. First of all, see, first thing is you need to identify what is the cause of bleeding. At the same time, you should stop the site of the bleeding. The second thing is, same time you have to replenish whatever the loss is there. Even though if you take time to see, identify, suture it, it will be almost half an hour. So meantime, whatever the blood is there, it will be out and the patient will be in shock. So someone should go immediately for cross matching and get the blood and transfuse, or put large IV cannulas and transfuse either hemosil something. Okay. So the main thing is first 2 large IV bore cannulas, as we know. put monitor cross this crystalloids, start crystalloids, and type and cross matching for the blood, get the blood, start off the blood immediately, and one will be looking after that, other will be exploring the uterine cavity. Okay, sometimes even if it is difficult to explore, we can put it under general anesthesia. The patient will not be cooperative, she will be having pain. So what we do, we will explore it under general anesthesia so that it will be comfortable and we can identify very fast. So first explore the uterine cavity, and starting from either go from below to above. So vagina, cervix, next uterus, at any level the defect can be there. You need to explore. First thing, after that what we need to see is, see whether the uterus is tonic or not. Whether the uterus is, how can we know whether the uterus is contracted or not? It is compared with what? After delivery it is compared with cricket ball. How hard the cricket ball is. So the uterus should be as hard as cricket ball. If it is not as hard as that, we can definitely say the uterus is, if it is a if it is not a retracted and a relaxed uterus, it will be soft, so soft. Okay. So we can, by that itself we can say that the uterus is not contracted or retracted. And one more thing is, so now we should give treatment, emergency treatment for this uterus retraction. First what we start, first drug is oxytocin. Now what is prophylactic management of, active management of third stage of labor? What are all the components of active management of third stage of labor? Active management. What do you mean by active management? Okay, one is oxytocin. So prophylactically oxytocin is given. Oxytocin is not given until unless the patient lands in the PPH. Okay, oxytocin is given even before the patient lands in PPH to prevent PPH. It is called as prophylactic oxytocin. Okay, it is one of the management. Third stage. What is the other 2 points in active management? Previously asked for you. Uterine massage. Okay, once the placenta is out, go for uterine massage. Next is controlled contraction. Okay, controlled contraction, uterine massage and oxytocin. So you have given oxytocin, but still it is not contracted, still it is bleeding. Next drug what you want to give immediately? Methergine. So methergine is the drug which is given. Previously it was given as a prophylactically, but nowadays the active management of third stage of labor, the book says oxytocin. Okay. What are the contraindications of methergine? Where we should not give methergine? Yes, exactly. Pre-eclampsia and eclampsia, never give methergine because it is going to cause hypertension still more. So never give methergine. Next. Yes, that is very important. What we do immediately after the delivery of the first in, will give methergine. Why? What happens if we give methergine after first delivery? No. Methergine is given to prevent bleeding, not for placental separation. What will happen? The uterus will contract, the uterus will close, os will close. Now the second baby is inside, only first baby is out. Now I should deliver second baby. If you give methergine, the os will close. How the second baby will deliver? Okay, so don't give methergine. One more very important indication where methergine is contraindicated. Methergine is contraindicated in, very frequently asked for you, methergine. RH negative pregnancy. In RH negative pregnancy, methergine is contraindicated. So what are all the contraindications for methergine? Preeclampsia, eclampsia, next. After delivery of the first in, next. RH negative pregnancy. So these are all the contraindications. And one more. One more. I will tell you in next slide, that will come. Okay. So you give methergine. Even methergine, it is the uterus will not contract. It has not contracted. So what is the next line of drug? You gave first which drug? Still it did not contract. Second drug? Third drug? What is this PGF2 alpha? What is PGF2 alpha? What prostaglandin? I say it is misoprostol. Misoprostol? F2 alpha. Carboprost. It is nothing otherwise called as prostadine. Carboprost. Then what is dinoproston? PG? Misoprostol? Even is misoprostol. E2 is Dinoprostone. Where do we use misoprostol? Peptic ulcer. Abortion. Okay. Termination of pregnancy. Next, other than that, even misoprostol, prostaglandin even is used in PPH. Nowadays, even it is used as prophylactically, but not as per the books. But misoprostol parectally we are giving, or perorally also we can give. Okay. So misoprostol is PG even. Where do we use dinoprostone then? E2. Dinoprostone is used for what? PPH prevent cheyadaniki vaadtama dinoprostone. Can we use it for abortion? Yes. Dinoprostone only one indication is for induction of the labor. Okay, not for termination of pregnancy, for induction of the labor. That's what we call it as cerviprime gel. So we put cerviprime, once you can see in the labor room, they'll be using cerviprime gel at the term for cervical dilatation. So that is dinoprostone. PGF2 alpha is carboprost, where it is used in atonicity. Okay, but very important thing which you will forget is, ask the patient whether she is having a history of asthma. So even though you are in a hurry, but never forget the patient, you need to ask this history. It is very one important complication. If you give directly prostaglandin, the patient will land in vasospasm of the bronchial vessels. Okay, so asthma is one important contraindication for this. You have done everything, still the bleeding is not controlled. Now what you want to do? You gave all injections, whatever you know, you gave everything. You remembered something, you gave. Uterine tamponade. How do you go? What do you do for uterine tamponade? Balloon tamponade with what? What is name of the tube? The name of the tube is Sengstaken Blackmore tube. So the name of the tube. So what do? We inflate the tube, something like a Foley's catheter. Even if there is no such a kind of tube, just in an emergency, in a peripheries, what they'll do? They'll put a Foley's catheter and inflate it. Okay. So they'll inflate. What it will does? Once you inflate the Foley's catheter, it is going to compress the vessels. Okay. So Sengstaken, whatever the mechanism is same, either Sengstaken Blackmore tube or the Foley's catheter. Okay. So even you have done that, uterine tamponade you have done, still the bleeding is not controlled. What you will do? Now, no option. Take her for surgery. Open. So open. What you are going to do? Going to remove the uterus. Okay. Okay. Karthik will remove. She will be behind you, the patient. Okay. Before that, there are very important things. Why I am telling you in a sequences, it was asked for you. Previously, one question from AIMS came like this. They asked the sequence. So the sequence was asked for you. So after taken tube, still the bleeding is not controlled. Now I can ligate vessel. Now I don't want to remove her uterus. Always remember, the uterus never should be removed until unless any other methods fails in PPH. So if all the methods have failed, then there is no other option. Then only go for hysterectomy. Okay. Even prior to that, I have got many options. I can apply sutures, some separate sutures. What are all the sutures you know? What is B-Lynch suture? What is B-Lynch? This is the uterus. So this is the cesarean section. Suppose a case of cesarean section. So we go from here. First we'll hold the lower flap. We'll go through this. We'll first take one bite. Next take one bite through the upper flap. Then go posteriorly. Posteriorly come like this. Okay. From posterior to anterior, come once again like this. Go posterior, come here, ligate these two ends. This is called as B-Lynch suture. What are all the other sutures? What are all the other sutures? What is Hayman's? Hayman's suture. So we are going through this incision. Hayman's is so simple. No going through this incisions and all. In Hayman's suture, what we do is simple. Directly go through this. Anterior wall and posterior wall, directly puncture the uterus, come here and ligate here. Okay. Same thing you need to do on this side. Okay. This is Hayman's sutures. Okay. So there are various types of sutures, but remember B-Lynch was asked for you. Brace sutures. These are called as brace sutures. So B-Lynch was asked for you previously. So even I have applied sutures, still the uterus is not contracted. It is still bleeding, atonic. Now what I will do? I have got an option of what? Ligating the vessels. So the blood supply to the uterus, I don't want to stop the uterus, I can just stop the blood vessels. If I stop now the blood vessels, the uterus will undergo atrophy, yes or no? Then why I can go directly for hysterectomy, no? Why I have to block the vessels, which is very difficult? The uterus will not undergo atrophy or necrosis even if I stop the vessels. Alternate vessels will take over. It will take time for the alternate vessels to develop. So the uterus will never undergo atrophy or necrosis. Okay. So what I'll do? I'll ligate, and very important thing is first I'll go for hypogastric artery ligation. The bleeding is not controlled. I will ligate ovarian artery. Okay. Where is the ovarian artery? So this is the tube. This will be the ovarian artery. Okay. This is the uterine artery. So I can ligate here, or I can ligate the uterine artery here. So wherever I want, I can ligate any vessel. Still, if even this is failed, now I want to ligate the main artery. What is that? Internal iliac artery. Which internal iliac artery? How many divisions are there in internal iliac artery? Anterior and posterior. Which division you want to ligate? Which division you want to ligate? Anterior division. Here I want to ligate. Very important thing. Anterior division I am ligating. What are all the branches of anterior division? What are all the branches of posterior division? మీరు చెప్పాలి, వీలు కాదు. థర్డ్ ఇయర్స్ అంటే ఫ్రెష్ ఫ్రమ్ అనాటమీ. Anterior, posterior. What is the clue? Clue enti? Already it is given in your books. Shiv obtained. Tell me the clue. Shiv obtained. What did Shiv obtain? మీకు ఏం కావాలో అదే వచ్చింది. శివకు కూడా ఏం వచ్చిందంట? Maximum marks in PG. Shiv obtained maximum marks. Don't write. This is already in all your PG. ఏ book తీసుకున్నా దాంట్లో ఉంటది clue. So now tell me. So I gave you clue. Now tell me the divisions. Superior vesicle, yes. Inferior vesicle. Obturator. Next. Yes, correct. Middle rectal. Next. Next. One more M is there. Gluteal. Okay. Next, what is this? INP. Internal pudendal. So this is the clue. Superior vesicle, inferior vesicle, obturator, middle gluteal, internal pudendal vessels. Okay. Which was asked. Anyway, that you will deal in anatomy. It's no more my topic. So I just told you because you can remember anterior division of the internal iliac artery, not the posterior division. Okay. So the final, everything I have done, but still the uterus is not contracting. What I will do is go for hysterectomy. Just remove the uterus. That is the final resort. So normally if you give everything, the uterus is contracted. But in a case of coagulopathy, what is the management? Coagulopathies. Because no atonicity, uterus is contracted, but it is defect at the bleeding level, at the micro level. So what you are going to do with coagulopathy? Replacement. What replacement you want to give? So either fibrin, whatever wherever it is defective. Okay, main which was asked for you was recombinant factor 7. So it was the thing which was used in coagulopathy. Okay, go for uterine packing. Next, cryoprecipitate and FFPs. These are most frequently used three things. First we will go for FFP, cryoprecipitate, and if even still the bleeding is not controlled, I will go for recombinant factor 7. So for coagulopathies. Perineal tears. Coming to perineal tears, how many degrees of tears? Fast. Yes, correct. 4 degrees. First degree, second degree, third degree, fourth degree. So tell me, from either from above behind or behind above go. What is fourth degree? What is fourth degree perineal tear? Rectum muscles, huh? A muscles, which muscles? Be clear. Sphincter. Okay, first you want to tell first. So first degree, second degree, third degree. Which one you want to tell first? So first is only vaginal mucosa. Exactly correct. Next. Second degree. Mucosa, and what is there beneath the mucosa? beneath the mucosa emuntadi? Submucosa na. Which part is lacking submucosa? Which genital organ is lacking submucosa? Tubes, fallopian tubes. Okay, beneath the mucosa what is there? Muscle layer. So simple. So if mucosa along with muscle, which muscles are involved specifically? One body. What is there? So that is there. Third degree means? Third degree? Not rectal mucosa. We will come under fourth degree. Third degree is along with mucosa, along with muscle. What is there? Sphincter. Anal sphincter. Sphincter, if it is involved, it is third degree. What is fourth degree? So everything plus rectal mucosa. Suppose if we take this is the vaginal outlet. This is the vaginal outlet. So this is the anal opening. Okay, this is the sphincter, anal opening. This is the vaginal opening. This is the urethra. Okay. Episiotomy. What is the meaning of episiotomy? We are going to give incision here. Left or right, whatever may be. Okay. So if the only mucosa inside the vaginal mucosa is involved, only this is the mucosal part. It is involved, it is first degree. Below this is and all muscle. So if this is involved, it is second degree. So even if it extends even to the sphincter, even sphincter can extend because the inside here and all sphincter muscle is there. So even sphincter can be involved. That is third degree. Not only the sphincter, just even though the sphincter is there, but still mucosa is intact. But now the extension was totally into the mucosa also. That is fourth degree. So this is how we label it as perineal tears. What is the treatment of perineal tear? Suppose some patients like in rural areas, they won't bother, they'll just go delivery. But she came after 3 months. She came after 1 month telling that doctor, I had delivery at home, which is very quite common, not at all a rare condition. Doctor, I had my delivery at home by Daya, but now I feel something is loosened and something, a opening is there. After 1 month she came. So when do you want to do it? Once again, when you want to suture, the question for you is when. She came after 1 month, when you want to suture it back. 3 months, after 3 months, don't do immediately, okay? Because after 3 months only you need to repair. Once a perineal tear, either do it early, I mean as soon as the tear is there, do it, suture it. If the tear, if you are not able to suture it, suppose she comes after 10 days, 15 days, 1 month, don't do it. Ask her to come back after 3 months, then go for the repair, okay? So that is the treatment of perineal. Cervical tears, most common, these are the very dangerous and excessive bleeding. Most common cervical tear is seen on the left lateral, which was asked for you. So left lateral part site is the site where the cervical tear is common. So in treatment for cervical tear is go for sutures, matrix sutures, that's it. Hematoma, which hematoma is common, supralevator or infralevator? Akkada ichchanu anukunta. Infralevator. Infralevator is very common, but the most dangerous is supralevator. Why supralevator is most dangerous? Because so this is the vulva, this is the vagina and vulval outlet. Inside the levator muscle is there. Whatever the infralevator, it is seen as vulval hematoma. Totally the vulva will be, she undergoes not. This is even frequently seen. So you have done a delivery. So you after 6 hours or 8 hours, you want her to shift from delivery room to other ward. So you'll just examine whether she is bleeding or not. Meantime, she'll be developing, her vulva will be this much size, as if like a cricket ball, more than a cricket ball. If everything is seen outside, that is infralevator. It is below the levator muscle. Nothing is seen. But once you check her pulse and BP, she will be in shock. The bleeding is above the levator. I mean, it is collecting inside. That is supralevator. The most common cause is rupture uterus. Okay, in a case of rupture uterus and all, we can see it because it is inside the peritoneum. Whereas infralevator, we see it outside, and management of infralevator is easy because infralevator, we take her under general anesthesia, we identify the site where the bleeding is there, we suture it. Okay. Rupture uterus. I want to cover even rupture uterus also here. What are all the causes of rupture uterus? Yes, exactly. Obstructed labor, which was very frequently seen. Next. Other than rupture uterus, other than obstructed labor. Other than, what are they? Mainly MTPs. MTPs, they perforate. Mainly they can perforate and they can land in rupture uterus. Okay. Any prior cesarean section, most commonly we see, not a normal patient, a previous cesarean section, she will land in a rupture uterus. So if she's giving a history of prior cesarean section, rupture uterus risk can be there. So if you want to give a trial for normal delivery this time, previously today my patient has come. Previously she was cesarean section. She asked me, doctor, please do a normal delivery this time. What do we call it as? Complete. V-back, no, long back. V-back is long back. Lakh, trial of labor after cesarean section. We call it as trial of labor after cesarean section. Lakh. So any previous cesarean section patient, now if you give a trial, be careful because she can land in rupture uterus. Other most common what we see in rural areas is obstructal labor. So even while applying forceps, I'll tell you in the next instrumental delivery, forceps itself can cause rupture uterus. Okay. Most commonly either the cervix or the uterus, most common site is left lateral wall. Okay. Treatment is nothing but suture. If that's whatever the part is there, you can suture it off. Yes, tell me. Baling suture. Suppose if it is uterus plus cervix, both are only uterus. B, if it is uterus plus cervix, both. నా బొమ్మను చూసి చెప్తున్నారా? Now I understood. I should be very careful in drawing whatever the diagram. It is only I am applying on uterus. I will never into the cervix. Okay? There is no space. There will normally ఈ బొమ్మలో కనిపించేంతగా మీకు కనిపించదు. During cesarean section, I will not have that much space to go into the cervix and to come back. What I have shown is this is the upper segment. This is the lower segment. That's it. So it will not involve cervix. It is only the uterus. Whatever the sutures, Heyman sutures or Baling sutures, they are applied only on the uterus, not on the cervix. Yes, next. Sure? Okay, is it clear for everyone? What is ergometrin? Methergine. Methergine is nothing but methyl ergometrin. Okay? Next. Sure? Only multigravida, no other thing? Once again think about the causes. Only multigravida, atonicity cause. This is a PJ bit. PJ bit. If I say PJ, you will go for more options. Even PJ has got a single option. Multigravida. Next. All are risk factors for PPH except. Think about 40s, whether the 40s are there or not. If it doesn't contain any T, that is the answer. See, abruptio placenta can be the answer, but not hypertension. Okay, abruptio placenta is a complication of preeclampsia, but not directly hypertension. It won't cause hypertension with abruptio, then only the bleeding disorder. Okay, macrosomia comes under which T? Big baby. Overdistension, causes of the overdistension. Tone. Okay, twin pregnancy, overdistension. Hydramnios, overdistension. So the answer is hypertension. Most common cause of PPH. Will not occur in which of the following? Why preterm labor if the baby will not land in PPH? తొందరగా అయిపోద్దా? Which is answer? ABCD. Answer is A. Why you are thinking so much? Just think any T. If no T, that is the answer. Preterm labor. Next. Answer fast. ABCD. What is the answer? Answer is D. 24 hours. Next. ఎవరు పోస్టర్ అనింది? ఎవరు అసలు ఎవరు అనింది పోస్టీరియర్? చేతులు కాలు కట్టేస్తాను ఈరోజు వాళ్ళకి. పోస్టర్ డివిజన్ ఇంతసేపు ఆ బొమ్మలు గీసి షివ్ ఒప్టైండ్ అన్ని కష్టపడి చెప్తే పోస్టర్ డివిజన్ అంటారా? సో ఆన్సర్ ఈస్ యాంటీరియర్ డివిజన్. నెక్స్ట్. నౌ ఆన్సర్. Which is not used in PPH? What is even? What is F2 alpha? What is E2? Where do we use it? Fast. ABCD. Retained products. Why the product is retained? Because it is not expelled outside, because the uterus is not contracting. So it is the atonicity of the uterus. Answer is A. Next, now answer this. Is it clear why the order is very important for you? This was asked previously. So this was PJ bit or AIMS bit. Okay, the order is very important. They can ask you like this. Okay.